Good evening, everyone. We are going to discuss mm, necrotizing enterocolitis. That is one of the important topic. Introduction part is oh, it is one of the commonest GI emergencies that is reported from neonatal intensive care unit, and it can occur in the form of endemic and epidemic occurrences, and more than of 85% cases are usually seen in less than 32 weeks in very low birth neonates. From developed countries, the incidence is usually around 2 to 7%. For All India Institute of Medical Science NICU, this rate is around 5.8% in the year of 2021. Then risk factors are prematurity, hypoxia, sepsis, abnormal colonization of bowel, ischemic reperfusion injury, umbilical artery catheterization, H2 blockers, and broad spectrum antibiotics. Then, antenatally detected blood flow abnormalities, which can be either in the form of absent or reverse and diastolic flow. Then, expressed or exclusive breastfeeds protects against NEC by altering the gastric pH and increasing the intestinal motility, decreasing the epithelial permeability, and altering the composition of intestinal bacterial flora. There is also said that there is no increased risk of NEC with early introduction of feeds, or if there is faster rate of enhancement of feeds. Then there was report that which says meta-analysis of 12 RCT was done comparing formula feeds versus donor human milk in preterm infant. It showed that the preterm infants fed with formula had approximately twice the incidence of necrotizing enterocolitis with a relative risk ratio of 1.87. Then if we talk about the pathogenesis part, it is multifactorial. Immature host immunological system is responsible, and then altered intestinal microbiome, that is dysbiosis. Then what is the milk substrate, and mucosal injury and inflammation is the final culprit. So the most common site that is has been mentioned in the literature is distal small intestine and proximal large intestine. Pathological hallmarks include coagulative necrosis, which occurs in the form of hemorrhagic ischemic inflammation and bacterial overgrowth. Then if you talk about the uh, what are the cytokines that are responsible, IL-22, interleukin 37 receptors are TL4 inhibitors and AHR activators that you have to remember. And other therapy include stem cell therapy, probiotics, surgery, that which we are going to discuss. Then if you talk about the clinical features, so clinical features, it commonly present as a fulminant and rapidly progressive illness, which may present as a slowly progressive illness or with abdominal distension and features of sepsis and ileus. Extremely preterm neonates, one should have high index of suspicion for early diagnosis. Then age of onset is something which is inversely related to postmenopausal uh, mm, age at birth, that is around mean 12 days with a PMA of 29 to 33, 31 weeks. And then there is a staging which is called as modified Wells staging. So that include three stages: stage 1A, stage 1, and stage 2A, stage 2B, stage 3A, and stage 3B. So we have to remember certain things. For example, in stage 1, one have to remember that there is a temperature instability along with anemia and bradycardia, and local signs include increased pre-feed aspirates with local with mild abdominal distension, and occult blood stool in there will in 1A, and in 1B there will be gross blood in the stools. Then radiological signs, they can be normal or mild ileus. So treatment is patient baby should be NPO. Consider antibiotics for 3 days when the cultures are already sent. 2A include there will be same local signs with absent bowel sounds and prominent abdominal distension and abdominal tenderness. So one has to do for the also monitor the abdominal girth measurement. Then radiological signs will include ileus, pneumatosis intestinalis, and baby has to be NPO, and also antibiotics need to be continued for 7 to 10 days. In stage 2B, there will be similar findings along with mild metabolic acidosis and thrombocytopenia. So 2A will include abdominal wall edema along with palpable loops and tenderness. Now the important thing is in 2A there will be intestinalis pneumatosis, but the portal venous gas pattern will be seen in stage 2B. Here is all treatment the same with antibiotics should be continued for 14 days. Then the 3A will include 2B include with the hypotension, bradycardia, mixed acidosis, and disseminated intravascular coagulation. Then same as 2 with worsening abdominal wall edema, erythema, and induration. There should be signs of generalized peritonitis and marked tenderness, and there will be a definitive ascites. In 2B, it can be or it cannot be present, but in 3A, it will definitely present, and treatment will include increased IV fluids along with inotropes and assisted ventilation with abdominal paracentesis as and when required. For stage 3B, shock will be worsening with the deterioration in laboratory signs, and local sign will be same with along with there will be a pneumoperitoneum, and treatment will be surgical intervention. Then if we talk about the systemic signs, so systemic signs include respiratory distress with increased episodes of anemia, bradycardia, and temperature instability, and also include lethargy. Child will be irritable with poor feeding, and there will be a decreased peripheral perfusion along with the pallor. So one can notice acidosis and hyperglycemia on lab findings along with decreased urine output. Then there will be chances of bleeding diastasis, that is secondary to sepsis, and abdominal signs will include increased gastric aspirates, abdominal distension or tenderness, blood in the stools, peritonitis, abdominal wall erythema, vomiting which may contain bile or as well as blood stained, and ascites will be there. And then if someone will talk about the investigation, so investigation will include anemia, low total leukocyte count with left shift, low platelets, and metabolic acidosis with hyponatremia, that is slowly going to be a refractory hyponatremia, and occult blood in the stool. Blood cultures are usually positive in around 40% of the cases. Classical triad, which I just talked about, there will be a severe refractory hyponatremia, persistent metabolic acidosis, and thrombocytopenia. Abdominal X-ray, one should consider both AP as well as lateral decubitus left for a small pneumoperitoneum, and for a sick baby, crossed table lateral views can be considered. Then bowel wall edema, and hallmark sign will be pneumatosis intestinalis that we are going to discuss in the next slide. Portal venous gas and gasless abdomen indicating ascites with fixed bowel loop on serial X-ray. That means there is no peristalsis. Frequency will include frequency I mean, how much one should repeat the X-rays? It depends upon the severity of NEC, and also it will vary from 6 to 24 hours, and depending upon the whether there is any clinical improvement or there is just the deterioration. Then USG abdomen can also be done to see the ascites, bowel wall thickness, bowel wall perforation, pneumatosis intestinalis, and portal venous gas can also be seen. And the very low birth, extremely low birth weight new infants or the neonates will have only the abdominal distension, and they are more prone to the pneumoperitoneum. So pneumatosis intestinal is something which is common after the 30 weeks post menopausal age. Then these are the two x-ray that I was discussing about. So the portal venous gas, you can see the pattern, and pneumatosis intestinalis arrow indicating intramural gas in the bowel wall with two layers that can be seen. So that is the bowel wall gas. Then there is one investigation that is called as near infrared spectroscopy. It include non-invasive measurement of O2 consumption of tissues in real time, and it can assess potential ischemia of the bowel. So there are studies which says that if there is a reduction in regional splanchnic saturation, which is a warning sign for the vulnerable neonates, and it also can predict bowel necrosis, perforation, and whether there will be a need for surgical intervention, that is 3A 3B, and the also will be helpful in to assess whether there is increased morbidity and mortality. So biomarker include fecal calprotectin, intestinal fatty acid binding protein, claudins, and trefoil factor 3, which seems to be more promising. And then if we talk about management include, first thing is prevention. So prevention include the antenatal steroids, which helps in reducing the incidence of necrotizing enterocolitis, and standard enteral feeding. This is something which is recommended, and human breast milk feeding. Probiotics include, there is a meta-analysis of 30 RCTs and 14 observational studies which showed that there is significant reduction in the severe necrotizing enterocolitis, that is after stage 2 or more, with a relative risk of 0.57. However, a recent large multicenter trial with Bifidobacterium breve strain showed there is no reduction in the risk of NEC or death. Then supplementation of lactoferrin with or without probiotics has been shown to reduce the incidence of late onset sepsis and NEC. L-arginine is helpful, although the larger trials are still awaited to document that this is going to be a beneficial therapy. Medical management include especially where there is suspected or established NEC. These babies should be NPO with continuous gastric aspiration along with replacement by N/2 saline, and one should consider TPN for stage 2 and 3 NEC. Remove the umbilical arterial and venous catheters if there is any, to minimize the chances of ongoing mesenteric ischemia. Appropriate respiratory support should be in consideration, whether the child is needed CPAP or a mechanical ventilation, that should be assessed along with the circulatory support with the help of IV fluids. If there is a need to increase them, one should consider them along with inotropes, along with the invasive BP monitoring. Metabolic derangements, as we have already discussed, this will include acidosis and refractory hyponatremia that should be corrected, and blood culture should be sent along with the upgradation of antibiotic whenever there is increasing stage of the NEC. Then pain control and minimal handling of neonate is something which is very very important. Maintain hematocrit, arrange PRP and fresh frozen plasma if there is a evidence of ongoing DIC. One should monitor the renal function test along with the electrolytes, and also the IV fluids input output charting is something which is very important, along with abdominal girth monitoring and serial abdominal x-ray to see whether there is any response in the with the help of therapy. Then appropriate or as early whenever there is a suspicion, pediatric surgical review should be taken. Then surgical management include there are two indications for absolute indications for the surgery, which is pneumoperitoneum, so indicating bowel perforation, and second is presence of necrotic bowel, which can so in the presence of the if there is a severe and persistent metabolic acidosis or thrombocytopenia, persistent fixed loop on serial x-rays with lack of response to medical management. And surgical option include laparotomy along with the primary peritoneal drainage, that is usually reserved for very sick neonates, especially those who are extremely low birth weight or very low birth weight, which cannot withhold a long anesthesia. So that has to be kept in mind. Then the further are whether there is any difference between laparotomy or primary peritoneal drainage. So there is a study which describes peritoneal drainage versus laparotomy, and initial surgical treatment for perforated NEC or spontaneous intestinal perforation in preterm low birth weight infants. That was done by Rao et al. They have shown that there is no significant benefits or harms of peritoneal drainage over laparotomy. However, they included only 2 RCTs and had a sample size of 185 neonates. This trial do not distinguish isolated intestinal perforation from NEC, although they have mentioned that the 74% of these babies ultimately require a rescue laparotomy. Then prognosis depends upon the risk factors involved and the staging of the condition. So the overall mortality of NEC ranges from 20 to 40%, but approaches 100% in neonates with the most severe form of the disease, and other complication in severe NEC requiring surgical intervention include so these are the post-operative complications that can be present in these babies in the form of intestinal strictures. Then short bowel syndrome can be seen, and also the cholestasis along with the growth failure, and there is a significant risk of neurodevelopment sequelae on follow-up. So thank you. This was the discussion for the NEC. I'll keep discussing these topic from the surgical point of view as well. This is just the initial management part of the necrotizing enterocolitis. Thank you.